It is my pleasure to be here with you today and to talk in this edition of Frontiers in Liver Disease. And my task will be to review the optimal management of portal hypertension beyond beta blockers. Here are my disclosures. I am originally from Barcelona, where I've been professor of medicine for many years, and now I am emeritus in Barcelona, but I am professor of medicine in Switzerland at Bern University. And my task was to review whether there is a life beyond beta blockers. But the first thing I shall disclose is that there is a question mark on these things because we have nothing very well proved beyond the beta blockers, that I will extend on that furthermore during my lecture. So let's start by portal hypertension. As you know, this is a common clinical syndrome in advanced chronic liver diseases, mainly in cirrhosis, and that causes about 90% of all cases with portal hypertension in Western countries. I think it's a little bit less in India, but not much less. And it is defined by an increased pressure gradient between the portal vein and the inferior vena cava, which is determined clinically as the HVPG or hepatic vein pressure gradient, and the normal values of which are 2 to 5 milliliters of mercury. And the relevance of portal hypertension is that it is responsible of the complications of cirrhosis that make it a highly lethal disease and lead to the need of liver transplantation. And the toll of cirrhosis is very heavy. I put here data for 2015. Estimations were 170,000 deaths per year in Europe, 1,300,000 in 2015. So this is a very lethal disease. And all these complications of portal hypertension are reversible by decreasing portal pressure. So if you don't have portal pressure elevation, you don't get any of these complications, even if you have cirrhosis. So let's continue on that view further. In patients with cirrhosis and portal hypertension, the fever is not measured in degrees centigrade, but in millimeters of mercury. And in the thermometer, normal values are 0 to 5 millimeters of mercury. This is the normal range. But between 5 and 10 millimeters of mercury, there is a subclinical portal hypertension. It's a mild portal hypertension that will not give any clinical symptom. It's only an elevated portal pressure that may progress to further, but if not reaches 10 millimeters of mercury, it will never get into trouble. From that on, we call it clinically significant portal hypertension because it can be associated with all the complications of cirrhosis, varices, bleeding, ascites, SPP, encephalopathy, and even further, at 16 millimeters of mercury, we know that the risk of dying from cirrhosis is higher, and at over 20, there is an increased risk of dying from acute pericardial bleeding and other complications. So the further is the increase in portal pressure, the worse for the patient. So implicit in these concepts, there is two important consequences. One is that the complications of portal hypertension can be prevented or reversed by preventing the increase or by decreasing the HCPG above or below this margin. The second concept, which is important, is that treatments aimed at correcting portal hypertension have a greater potential of changing the natural history and improving survival than local treatments, as, for instance, paracentesis for ascites or endoscopic therapies for varices. And this is a very important concept because it is the basis for the rational treatment of portal hypertension using drug therapy. So another important concept is that the natural history of cirrhosis follows several stages. The first is a long, asymptomatic compensated stage in which the patients have a very good prognosis. And this can last for 10 years with an excellent survival, not much different from that of patients with without cirrhosis. So it's 1 year mortality is about 2%, and 2 years mortality is about 5%, not much different from normal subjects. This changes dramatically when the patients develop decompensation, where the prognosis drops to a 1 year survival of 60%, 2 year survival of 50%, which is like a malignant disease. So this it's very important. Prognosis in compensated phase is very good. Prognosis in the after the compensation is very poor, and this marks our approach to treatment. Another thing which is important is that the more common the compensating event is development of ascites. It's over twice as frequent as development of variceal bleeding, for instance. So this is the more common first decompensating event. It appears in 50% is the first. So I graphically depicted that in this slide. So you see the transition from compensated cirrhosis to decompensated cirrhosis and death or liver transplantation, sometimes heralded by acute and chronic liver failure. And the transition from compensation to decompensation is marked by the development of clinically significant portal hypertension. And this is followed by first ascites and other complications, variceal hemorrhage and encephalopathy. So the goal of therapy, the primary goal of therapy in compensated patients with a good prognosis is to prevent decompensation, not only to prevent bleeding, but to prevent any decompensating event that signals the transition to the poor prognostic phase of cirrhosis. Whereas in decompensated cirrhosis, we want to prevent death or acute and chronic liver failure or orthotopic liver transplantation requirements. So this is what we want to prevent here, and this is what we want to prevent during compensation. Secondary endpoints. Well, prevention of first bleeding is a secondary endpoint in compensated cirrhosis because this is not very relevant in terms of mortality. So this is a very different view from what it was previously before considering cirrhosis in stages. So it's that all studies were done to prevent bleeding, first bleeding or repeated bleeding, whereas now we think more in terms of preventing decompensation. Okay? Well, how can we achieve a reduction in portal pressure to prevent the complications of portal hypertension or to correct them? Well, for that, we shall consider that portal pressure is the product of resistance and blood flow within the portal system. And portal hypertension, increased portal pressure, is first determined by an increased resistance. And this increased resistance in cirrhosis is located at the intrahepatic circulation and is due to hepatocyte injury, fibrosis, endothelial dysfunction, which increases the hepatic vascular tone, and inflammation. So these are the reasons for increasing resistance. When the increase in portal pressure determined by increase in resistance reaches above 10 millimeters of mercury, then collaterals begin to develop, and we have other factors arising. And these are splanchnic vasodilatation, diminished sensitivity to vasoconstrictors, and phenomena such as bacterial translocation that altogether contribute to this vasodilatation and increased portal inflow. And this increased blood flow then contributes to increase further the portal pressure. And this heralds the variceal bleeding and the formation of ascites. So we can act on variceal, on portal pressure. Traditionally by beta blockers, what we were acting was on the blood flow by acting on splanchnic vasodilatation. So this is something which is effective in advanced stages of cirrhosis, but doesn't touch the initial factor. What is beyond beta blockers? Well, is these intrahepatic targets that we can try to address by interfering with the mechanisms leading to the increased intrahepatic resistance. So let's continue. Well, beta blockers. Well, the first report on the use of beta blockers in for the treatment of portal hypertension was the historic paper by Dr. Quebec that was published in the New England Journal in 1981. This was the first study. So the findings are still valid in 2020, and this is very remarkable for a medication, for a treatment to be still valid 40 years after its introduction. So this is a history of a success. So first of all, we have to acknowledge that beta blockers have been a big success. Next. Here we have what are the beneficial effects of beta blockers. And this goes beyond the reduction of portal pressure. And, for instance, the reduced collateral blood flow will decrease the variceal pressure and wall tension, which are the mechanisms intimately correlating with the occurrence of bleeding. Beta blockers decrease the intestinal transit time and gut permeability, and this decreases bacterial translocation and the risk of SVP in patients with cirrhosis that has been well demonstrated in meta-analysis. And the decreased angiogenesis caused by beta blockers has been linked to a potential reduced risk of HCC that is less well demonstrated than the reduction in SVP. So these are the beneficial effects. What are the inconveniences and the problems that we have with propranolol? Why we want to go beyond? Well, propranolol is safe, but have some contraindications and unpleasant side effects that make that not everyone is treated to them. So altogether, about 20 to 30% of the patients have relative contraindications or cannot tolerate the beta blockers. So these are not adequate for every people. Another thing is the limited rate of high hemodynamic response. We know that for propranolol to be effective, it has to decrease the portal pressure at least by 10%, in compensated stages at least by 20% in the compensated. And this is not achieved in all patients. In compensated patients, we achieve that in about 50 to 65% of the patients. In the compensated, it's only about 40%. And so this is a big limitation. And also, there is a debate on whether beta blockers in special circumstances in patients that have SVP or refractory ascites or hepatorenal syndrome, circumstances where the subject is particularly from a circulatory point of view, labile, if they are safe. So the consensus is that if systolic blood pressure is below 90, the heart rate is below 55, or the creatinine is increasing, it's better to halve the dose of beta blockers or to withdraw it temporarily until these circumstances have been overcome. So, because of that, we have to look for other things. And what we have beyond beta blockers? Well, the best alternative to traditional non-selective beta blockers is another beta blocker, which is carvedilol. And carvedilol is, as I will show you, more effective and safer than propranolol or nadolol. Carvedilol was initially developed to treat heart failure and arterial hypertension, and had, in these circumstances, never been associated with renal adverse events or any other kind of complication. So it's quite safe drug. In patients with cirrhosis, carvedilol, which is a non-selective beta blocker such as propranolol, causes a greater effect decreasing the portal pressure or the HVPG due to the fact that it also decreases intrahepatic vascular resistance because it also has anti-alpha-1 adrenergic activity. So these studies were acute administration, and they showed an advantage of carvedilol over propranolol. These were chronic administration, again, with an advantage of carvedilol over propranolol. On top of that, the rate of good hemodynamic response to carvedilol reaches almost 80% versus about 50% with traditional non-selective beta blockers. The dose is much easier to adjust because you have only 2 steps. It is much better tolerated by the patients, and it is because we give it at low doses that don't cause side effects such as shortness of breath, etc., which are imprisoned in patients with cirrhosis. And it is effective in both primary and secondary prophylaxis. All this is provided by we use it at the recommended doses, which go from 625 to 12.5 milligrams per day. Very rarely we use it twice a day, up to a maximum of 25 milligrams. And this is because the maximum effect on portal pressure is already reached by this low dose of 12.5. So increasing the dose will only increase the side effects, will not make it more effective. So this is the recommended dose. You don't need to go further. And because of that, it's very easy to target the exact dose that you need. So this has allowed to do studies that in circumstances that before were unsuccessful. So, and the more important study that has been recently done with beta blockers is the Prester study, which was trying to prevent the decompensation of cirrhosis in patients with compensated chronic liver disease and portal hypertension using beta blockers. And the beta blockers we were using was propranolol in those that were acute hemodynamic responders to propranolol, and carvedilol in those who were not responders to propranolol. So carvedilol was only used as rescue, let's say, for the non-responders. And all patients that had all clinically significant portal hypertension were compensated, had no varices or small varices not requiring therapy. These patients were randomized to receive propranolol versus placebo or carvedilol versus placebo on the basis of the response to beta blockers. So the trial, the more important finding was that beta blockers decrease first clinical decompensation. This is the behavior of clinical decompensation in the beta blocker treated group, and this is in the placebo group. And you see that overall it reduced by almost 50% the incidence of decompensation, which is very, very relevant result. And in most occasions, the event that caused the compensation that was prevented was the development of ascites that was reduced by 56%. And this is the first time that the medical treatment was shown to prevent ascites. So this is a very important message because it's highly effective in preventing ascites. The study did not show any difference in the incidence of bleeding, which is not surprising because for ethical reasons, all patients who were developing varices during the study were treated with endoscopy, regardless of each arm. It was double-blind. We didn't know if the patients developing varices were under beta blockers or placebo, so we treat them all with endoscopic therapy. So bleeding was not a relevant endpoint in that study. And an important finding also is that decompensation only occurred in patients without a hemodynamic response of at least a 10% reduction of HPPG or below 10 millimeters of mercury. So you see patients not achieving that response at a much higher risk of decompensation. It was 70% reduced in patients with a good hemodynamic response. And the good news for that is that this is almost invariably achieved with carvedilol. Actually, although the numbers were not enough to make a full statistical consideration for that, the protection achieved with carvedilol that was only used in non-responders to propranolol was even better than that of propranolol in responders. So it's nowadays the conclusion is that you can achieve that, you can achieve it much easierly, better tolerated, and with a greater effectivity in patients that receive carvedilol. So this is a new indication for the treatment of patients with cirrhosis, going beyond traditional beta blockers using carvedilol. Well, we said that this was beta blockers, and this is beyond beta blockers strictly. So these are the targets that we can have: hepatocyte injury, fibrosis, endothelial dysfunction, and inflammation. Let's look at what we have in practice on that regard. This has been elusive until very recently, but with the development of treatments that correct the cause of cirrhosis, etiological factors, we can help develop that. For instance, in patients with cirrhosis, with advanced cirrhosis, with portal hypertension, receiving direct-acting antivirals, at achieving SVR by 6 months, you have a significant decrease in portal pressure of a little bit over 10%. And this is baseline values categorized as these are clinically significant portal hypertension. This is above 12 millimeters of mercury, and this is above 16 millimeters of mercury. And you see that all these are positively influenced by the passage of time after achieving a good hemodynamic response. But even after 2 years, we have 50% of the patients, a little bit more, that still have clinically significant portal hypertension and that still are at risk of decompensation, which means that you have to continue to treat these patients for at least 2 years and then reevaluate the patient to see whether he still requires or not beta blockers. Another way of achieving a response acting on etiology is in patients with obesity or overweight, most of them with NASH, but not exclusively, by making diet, very well-controlled diet, and physical exercise. And in a program of 4 months of that therapy, we achieved the same decrease in portal pressure as with antivirals in hepatitis C. And you see that overall 40% of the patients had a good hemodynamic response just to these very simple things. And the same can be told about abstinence of alcohol, that also has this effect and has been also well demonstrated. So acting on etiology and a good, healthy lifestyle, including abstinence from alcohol, are key in patients with cirrhosis. What else can we do? Well, in terms of pharmacological agents, I will show you only what we know about the better characterized, which are statins. And we know that the statins, and particularly simvastatin, lower the portal pressure in patients with cirrhosis. As you see, this is a double-blind study that shows that placebo had no effect on portal pressure, but HVPG decreased significantly after treatment with simvastatin, and this has been corroborated in other trials. And this effect was independent of the patients being or not under beta blockers, and was particularly evident in patients that were already under beta blockers. So it's a rationale for combining both, and was accompanied by a marked increase in the hepatic clearance of ICG, which is a quantitative liver function test, which suggests that this was accompanied by an improved liver function, which is a combination of improved microcirculation and decreased fibrosis. On the other hand, in the lab, we have shown repeatedly that simvastatin has strong antifibrotic, anti-inflammatory, and liver protective effects that altogether make it treated to improve survival in patients with cirrhosis. And this was precisely what was tested in the next study, that was the PLEBS study, that was the use of simvastatin or placebo on top of standard therapy in patients who already have bled from varices. So standard therapy in these cases is non-selective beta blockers plus endoscopic therapy with van ligation, and in this case supplemented by simvastatin or placebo. And although rebleeding rates were not significantly different between simvastatin treated and placebo treated patients, the survival was much, much better in the patients receiving simvastatin. And this was so due to a reduced death rate in patients developing infections or developing bleeding. So simvastatin prevented deterioration and death in patients experiencing complications during the treatment. And the reduction in mortality was over 60% reduction, which is a very, very important effect. So, and we have done a series of translational studies showing the mechanisms by which simvastatin can protect from these adverse effects of infections and hypovolemia. Okay, the only important thing to remember is that in patients with child C cirrhosis, you have to reduce the dose of simvastatin by 50% to avoid toxicity, muscle toxicity. And the maximal dose should be 20 milligrams per day in patients with child C. In patients with child A and B, you can go up to 40 milligrams per day, but not in child C patients. Okay, the statins have been shown also to improve cirrhosis in epidemiological studies. One of the earlier and best ones was those done by Dr. Garcia Sal that compared statin users and non-users in the BA system in the States in terms of decompensation and death. And you see here that both clinical decompensation and death were much lower in statin users than non-users. And this was a propensity score match study. So this is a potential demonstration. It's epidemiological survey, but still it's in favor of the use of statins. And this other study is interesting. It's on the risk of hepatocellular carcinoma in patients with chronic viral hepatitis, that are complicated with hepatocellular carcinoma when they have significant fibrosis, is that these were reduced when you were using lipophilic statins that are metabolized by the liver and concentrate in the liver. You decrease the death rate or the formation of HCC in these patients. When you compare patients not on statins, with those taking hydrophilic statin, there is no benefit in terms of development of hepatocellular carcinoma. And what is the practical message is that the better benefits from statins in cirrhosis are to be expected from lipophilic statins, which are simvastatin and atorvastatin. Atorvastatin has been tested in animal models with good success, and simvastatin in all of our studies. Hydrophilic statins are probably less likely to be effective. So other drugs that target fibrogenesis are shown in that slide. So we can target the fibrogenesis by acting on liver injury, changing inflammation to restoration, improving hepatic stellate phenotype, or increasing degradation of collagen. And I've highlighted here the drugs that have been used, and I put in red those that have some evidence in humans. And so we have statins here with good evidence. The best studied is statins. And we have other drugs that have some good results. So these are FXR agonists, such as urticolic acid, and other more recent, that in trials have shown to reduce fibrosis, as the PAM-PPAR agonists, such as lanifibranor or urticolic acid, put it here. So, and also I've marked here anticoagulants, because anticoagulants have a potential to prevent activation of the hepatic stellate cell and induce the activation, because one of the factors that activate the hepatic stellate cells is thrombin generation, and this can be inhibited by these drugs. So there was one trial showing that anticoagulants may perhaps decrease fibrosis and advancement of cirrhosis in patients with cirrhosis. So my last slides are to show you the last thing on top of beta blockers, which is tips. And talking about tips, I will refer only to one of more recent applications, which is the concept of early tips. That's done in patients in whom they arrive to hospital with bleeding and have a high risk estimated by its Child-Pugh score. So patients with Child-Pugh score below 14 can be considered if they have enough risk as shown by being at least child B with active bleeding or child C. So this was the initial study. It was done by Dr. Garcia Pagan, and showing that in this high-risk group, mortality, failure to control bleeding or rebleeding was much improved by tips. And this is more important, mortality was very much reduced. Even if patients on the control arm, not receiving tips preemptive, received tips after failure of controlling the bleeding. So in spite of using tips in these patients, mortality was much higher when you use this strategy instead of advancing tips to a preemptive strategy. And these findings have been confirmed in large observational studies and more recently by a meta-analysis of individual patient data that is on press in gastroenterology. And this study that comprises a very large number of patients with cirrhosis, over 1,300 patients, shows that survival in overall population was decreased by using tips as compared to beta blockers plus endoscopic therapy. Early tips confirms that it improves survival in these patients with child B or C cirrhosis submitted to early tips. And this study allowed, because of the large number, to dissect whether in child B patients this was still the same, because in child C we already know that it was very effective. And so this is the population of child B plus active bleeding, the child B patients that were considered to need preemptive tips in the initial trial, and you show that this is true for these patients. But further, it was looked at whether these patients in the child C group, of course, this was very effective. In the study, look also whether there was within child B patients, there were some that benefited and some that didn't benefit in terms of survival. And what it was shown is the child B plus active bleeding that had a child score of 7 points had no survival benefit, but those that were above 7, that were 8 or 9, and this child C did improve. So we can say that it is well confirmed that patients with at least 8 points of child should receive early tips when they arrive to hospital due to bleeding, because this translates into survival benefit. So take-home messages: treatment of portal hypertension must take into account the clinical stage of cirrhosis. Eliminating the etiological factors and healthy lifestyles are important adjuncts in therapy, and non-selective beta blockers are still the mainstream of drug therapy. However, propranolol is no longer the drug of choice and has been substituted by carvedilol. So carvedilol is effective in preventing decompensation and in primary and secondary prophylaxis, and we have many studies showing that. And simvastatin is emerging as a new drug that, combined with non-selective beta blockers and EVL, can reduce mortality after variceal bleeding and has a potential to prevent also complications such as acute and chronic liver failure. So it's a good candidate for therapy, and we are awaiting more studies to confirm what is already known. Preemptive tips decreases bleeding and death in high-risk patients. This is very important because this has to permeate clinical practice. And as new agents, we are evaluating anticoagulants, FXR agonists, PAM-PPAR agonists, and cell therapy, which are still under investigation. And acknowledging my group in Barcelona, my former group in Barcelona, and my group in Bern, I will now close here and thank you for your attention. Thank you so much.
Thank you, Prof. And when you talk about statins, we know there are various groups of statins like the lipophilic, the hydrophilic. Are there any difference between various groups of statins with respect to reduction in portal hypertension?
Yeah, well, the only ones that we have assessed are the lipophilic ones, but we have assessed in animal models hydrophilic and lipophilic statins, and the ones that affect most the biology of fibrogenesis and generation of nitric oxide, which is related to its effects on KRF2 expression and transcription of protective genes in the liver. The more powerful for that is simvastatin and atorvastatin. The others are less powerful, which is in relation with the other thing. And the lipophilic have the potential, because these are metabolized in the liver, that are concentrated in the liver, so you make kind of more selective delivery to the target organ, whereas the hydrophilic are more generally don't have this preferential expression in the liver. And perhaps it's a hypothesis because of that. This study on prevention of hepatocellular carcinoma showed that this was limited to the lipophilic and not to the hydrophilic. In terms of toxicity of statins, we know that patients with liver disease have no increased risk of hepatotoxicity, because hepatotoxicity from statins is very rare, and the risk is the same in patients with cirrhosis or without. But in terms of muscle toxicity, that is a little bit dose related. It's an occasional effect, but it's a little bit dose related. This has been shown to be more frequent in patients with decompensated cirrhosis and high bilirubin. In our trial, in the Black study, we had 2 patients with muscle toxicity in patients that were above 5 milligrams per deciliter in bilirubin concentration, that were child C with jaundice. And we were discussing that with pharmacologists that showed in modelization of metabolism of simvastatin that these patients should receive maximum 20 milligrams. And this has been confirmed in the liver hub study that analyzed a small number of child C patients given 40 milligrams and having adverse events in those giving 40 versus those giving 20 that had no adverse events. So because of that, we recommend not to go further than 20 milligrams in child C patients. But I think that 20 milligrams will do the work even in compensated patients. So you don't need to go to such a high doses of statins to have the benefit. So it's important. Anything can do it.
Prof, we hear a lot about bacterial translocation and decompensated cirrhosis. And does modulating gut microbiota help in controlling portal hypertension? Is there any role for pre-probiotics in portal hypertension?
No. There is very little evidence for that, and there have been many attempts. Theoretically, there should be something on that, but in practice, when you look it and you look for it, you don't find it. And we were much in favor of that hypothesis, and we did a very large study in patients with cirrhosis looking at bacterial translocation by measuring LBP and by measuring the bacterial DNA in blood, which is a more sensitive index, much more sensitive than looking at LPS. And we only found evidence of translocation in patients with decompensated cirrhosis, never in compensated patients. And in decompensated cirrhotics, those admitted because of ascites, only 50% had some evidence of translocation. And we were comparing whether this translated into increased portal pressure. It didn't. The portal pressure was not influenced by that, but the level of pro-inflammatory cytokines was. So bacterial translocation increases pro-inflammatory cytokines, and because of that can be of risk for producing, for instance, acute or chronic liver failure, but not increasing portal pressure by itself. And the only thing that we could correlate in terms of hemodynamic effects with the presence of bacterial translocation was that patients with bacterial translocation had more evidence for endothelial dysfunction in the liver, that we explore by looking at vasodilation induced by a test meal and looking at the CPG response. And this was attenuated in patients without bacterial translocation, indicating a good hemodynamic response in the liver, vasodilating adequately to a stimulus for the endothelium, whereas in patients with bacterial translocation, this response was attenuated and did not translate in not moving the portal pressure almost. But this is probably a negligible effect, and the more important effect is that bacterial translocation does contribute to systemic inflammation, and this systemic inflammation can accelerate fibrosis progression in one side and can facilitate, and this is more important probably, the appearance of acute and chronic liver failure. But most instances of acute and chronic liver failure are precipitated. The more frequent precipitant is infections, and patients with bacterial translocation has been shown that have an increased susceptibility to sepsis and infections as well. So probably everything goes on that side, more than on the side of aggravating the portal hypertension by itself. And even in a recent meta-analysis that we published not that during this year, we found no effect of antibiotics on portal pressure in patients with cirrhosis. Taking, let's say, norfloxacin or rifaximin to decrease bacterial translocation, and they had no effect on portal pressure when given alone versus a placebo versus a control arm. They had an effect when given long term together with propranolol. So then it's probably they have some synergism on top of propranolol, and these antibiotics did reduce systemic inflammation as well. So the effects on inflammation are dissociated from the effects in portal pressure to a certain extent. So probably they go in the prognostic value of translocation. It's more regarding acute and chronic liver failure, systemic inflammation, than on strictly increasing the portal pressure.
One last question, Prof. You talked about preemptive tips in variceal bleed. Can tips be used as a disease-modifying therapy to alter the natural history of cirrhosis, to prevent a decompensation in cirrhosis?
What do you mean? We use beta blockers to prevent decompensation. We don't use tips to prevent decompensation. Why? Because in the 50s, when I was a kid or not born, somebody invented the surgical portocaval shunts. And they show very nicely that surgical portocaval shunts prevented totally the complications of portal hypertension, but caused encephalopathy. And the total deprivation of portal blood flow to the liver aggravated liver function. So when it was used prophylactically, the portocaval shunt prevented bleeding and ascites, but caused encephalopathy and reduced life expectancy because they aggravated the cirrhosis. So we knew from that time that you never should do a prophylactic shunt, because prophylactic shunts don't improve survival, because the risk of dying for a patient who's compensated is very low, and they have no risk of decompensation until the moment they have a much increased portal pressure. So it's better to abstain to do very aggressive therapies in patients who are not at risk of dying. So you have to adapt the risk of the treatment to the risk of the complications you want to prevent. So tips is for advanced cirrhosis. Other things, much safer, lifestyle changes, etiological treatment, these are for early stages. And probably statins also can be very effective given at early stages as other drugs that would influence fibrogenesis. This is where we are moving for.
Thank you, Prof. It's always been a pleasure to listen to you, and it's an excellent talk. And I'm sure there are more questions which we probably made it to you for your consideration.
Okay. Thank you.
Thank you very much, Prof. Thank you.
Thank you.